It's now my pleasure to introduce today's speaker, Dr. Ben Curtis. Dr. Curtis completed his dental school and pediatric residency at Baylor College of Dentistry in Texas. He is an American Academy of Pediatric Dentistry Harris Fellow and a diplomate of the American Board of Pediatric Dentistry. He currently practices in Big D, Dallas, Texas, where he utilizes an all-tissue laser in his daily care for pediatric patients. He enjoys spending time with his wife and three children on their ranch in East Texas or at Disney World. Unfortunately, it's closed right now, Dr. Harris, so thank you for getting it at the time and spending it with us instead. And with that, I'd like to warmly welcome and present Dr. Curtis.
Well, thank you so much for that warm introduction, and thank you all for joining me this afternoon, coming from Dallas, Texas here. And so let's get started. We've got a lot of slides to work through, and definitely I want to make sure I get time for your questions and to be able to answer those on Friday for you as well. So please join me back then. So who am I? I'm first and foremost a father. These are my three children here. Birdie Bell, she's 5. Dotson Powell, he's 3. And little Emerson Reagan is 1 year old. They're there on our ranch in East Texas, and they are my pride and joy. I did my dental school at Baylor College of Dentistry, which is now Texas A&M. Call it dental school there. And this is me and one of my buddies from dental school on our first injection. He hit the mark. He aspirated and got a blood vessel on the first try. So I love that picture for that. It's good memories, good times. Did my residency, as you said, at Baylor and Children's Medical Center, Dallas. I'm still on staff there at the hospital at Children's. And did a great Harris Fellow project with the American Academy of Pediatric Dentistry. A board certified pediatric dentist by the American Board of Pediatric Dentistry, and in private practice here in Dallas, Texas, where I utilize the all tissue laser pretty much on a daily basis for the most part there. I use the laser so much that BioLace reached out to me to be a consultant for them, where I try new products for them. They'll send me things, they'll give them my feedback on it. I do training courses now for them as well. So hands-on training, didactic things, in doing lectures for resident programs and things like that as well on the topics of the dental lasers. So it's become quite a passion of mine. And I am doing an honorarium for them today for those presentations. So we appreciate their support. An overview for what we're going to discuss today, we're going to review the laser basics. So if we can understand kind of the simple part of how the laser works, it's going to help us understand so much more clinically how to apply that. And so I honestly believe we need to understand what we're doing and how we're doing it, how we can use that to help make us the most efficient and effective in our efforts. We're going to focus on how we can help have less shots and safer care, and how we can look at a few cases where we can do composites and crowns with a laser involved and really have quick, efficient treatment where we can simplify it for the patient and have really great results with a comfortable experience for the patient as well. My goal for you today is really to have a better understanding of how the laser can fit into your pediatric practice. Being a pediatric specialist, my heart is with the kids and being able to provide them the best experience they can, but really making sure we can keep it efficient for them. Their attention spans are so short, and we want to keep it safe for them. Safety is always a priority. So laser 101, let's go back to the basics here, okay? We are gonna keep it simple, all right? Our initial barrier for the laser is, when we're looking at acquiring it into our practice or even discussing it with staff or parents, it's really understanding what is this laser and how to keep it simple, like the Staples easy button. So we're gonna keep it easy today. Basically, it's a fancy light bulb, all right? And that's how I describe it to parents. Parents think you're Darth Vader here and that you're part of Star Wars, but really you're operating with a very tiny, very specialized light bulb, and you're using that light energy for the good. Laser simply is an acronym for light amplification by stimulated emissions of radiation, all right? And so that's just a fancy way. So thankfully we call it laser. We don't have to say all of that. I love this diagram here where it's the spectrum of light, and it just reminds us where we're functioning within. We've got the visible light that of course we see, the UV light and the infrared. So we are functioning within the infrared light spectrum here, and we've got different lasers that can go into that. Diode lasers of different wavelengths, Nd:YAG, erbium chromium, which is going to be what we're going to focus in, and then of course our CO2s. So even within the infrared spectrum, the lasers are all over the wavelength process there too. And it's the active medium, thus the erbium chromium or the CO2, and the wavelength that they function within that really determines how we can best utilize those for the tissue interactions that we want to have. So the focus of our discussion today is going to be revolving around the BioLase Waterlase I+ laser. This is what I chose to utilize in my private practice. And one of the things I really like about it in comparison to some of the other ones is how user-friendly this is. You're able to do both soft tissue and hard tissue procedures. It has a very simple touch screen that you can see here that you just press the little buttons. There's not a lot of fuss about calibrating it or moving things around. It's pretty darn user friendly. And I love to be able to train people to use it and really help them hone their skills on utilizing that. And it's also really easy to move around from room to room too. So a couple of different things when we're thinking about choosing a laser on the market there, to be thinking about user friendly, easy to operate, and easy to get around there as well. I utilize it for all sorts of different things, from frenectomies to soft tissue. I love to do mucocil removals on little kids. That's one of my favorite procedures to do. I love it for the hard tissue. A lot of people in the laser field are really into frenectomies within pediatrics. My passion really lies a lot more in restorative portions of it and really being able to change that experience completely for that child by utilizing a laser. And I hope I can share some of that excitement with you today. Another barrier that we come across is how does this light or this laser work for us? So what is it doing? How do we get it to do what we want it to? And really understanding that the laser, be it a diode, an ND, erbium, or a CO2, are attracted to different things. The chromophore, it's what the wavelength of that light is attracted to, where it absorbs within. The erbium is absorbed highly into water, and it also absorbs some into hemoglobin, so blood, where the diode is not really attracted at all to water and is absorbed more in blood and melanin, so pigmented type things. The CO2 is also water and hemoglobin. So these two can have similar functions, but I love this diagram because it reminds me what the laser that I'm utilizing is attracted to, what it wants to work on. It wants to work on and is attracted to water. This laser loves water. So if there's a lot of water in it, it's going to have a great effect on that. So when we think about teeth structures and everything as it relates to water content, healthy enamel has about 12% fluid and liquid within those hydroxyapatite crystalline structure. And then we've got our dental tubules, which have more water or more fluid within that. And then we think about the carious tooth structure that's all mushy and infected and gross. There's a lot more liquid and water content in that. So thus, the laser is going to be a lot more attracted to that. There can be up to 50% or so water in those infected lesions. And so the laser is going to home in on that like a missile with a radar beacon on that. It's really going to focus on that a lot more. And primary teeth are anatomically different than permanent teeth. And we do see a little bit more water in primary teeth as well. So always important to remember how our laser is working for us. And this laser likes water. So it's highly attracted to those caries. I'll give you some pro tips throughout this, as I like to call them. And those are just things we want to make sure that we're focusing in on. So for the hard tissue, what is it actually doing to that? This kind of comes from out of the AAPD reference manual, but the hydroxyapatite is mostly made up, or the two structures mostly made up of these hydroxyapatite crystals and some water. It actually heats that up and then vaporizes it into steam. That steam expands and bursts into small particles. So that's what it's doing to the tooth. It's heating up that liquid within it, or the liquid within the caries, and basically it's making tiny little controlled bursts of explosions, or dynamite, if you want to think about it like that, but on a very, very finite controlled manner. And we'll talk more about how this laser in particular has controlled it on a very, very small scale, which makes it very efficient for us to use on the small primary teeth, right? But that's kind of the nitty-gritty about what is actually going on at the tooth level there. The big barrier here, another one is, well, how do we use this? So if that's what's going on, how do we actually get that to work for us? So we're gonna focus on the basics, all right? Another great thing that makes this laser in particular kind of user-friendly for us is it has a familiar feel. So this is the handpiece here when we're utilizing the laser. This is the gold handpiece. It looks almost just like a traditional high-speed handpiece. It has a little glass tip that inserts here. This is the aiming beam. Now remember, the laser light is invisible. So within this is an aiming beam. And then it does spray a small amount of water out of the end of this to help keep everything nice and cool and clean. All right, it has a little light that focuses there to provide light down into your area as well, just like a high speed. So it has a very familiar feel there once again. These diagrams are really great. I like this one because it shows the explosion of that decay there. And it's showing how that tip fits into the handpiece here. And the laser beam comes out the end of the tip. And it basically heats that area up and destroys that. It makes a popping noise as it makes those little explosions. And the laser, theoretically, is killing a lot of bacteria in there and thus making this area more decontaminated and cleaner than it was before. So it's really great for different specialties to utilize for things where we want to eliminate the bacteria there. We don't think about that as much in pediatrics, but definitely we're blasting those areas to smithereens there on a tiny little bit at a time. One of the things we have to remember is this is not a burr. It doesn't function like a burr, although it looks similar to a burr. So we do not touch it to the tooth, okay? It only functions out of the end. It comes out of the end of that little tip. We don't scatter out of it. It goes straight out, and it doesn't cut on the sides like a 330 burr would do when we're trying to cut a class 2 composite. It goes straight out the end, and we'll show some images of what that is. But just like we have different types of burrs that we would put into our handpiece, we've got different tips that we can utilize too, which is a really nice function for restorative. So if I'm doing something, let's say a crown, where I might need more of a broad, but not as deep of a cut, where I might want to remove off more surface level, then I might go with an 8 tip. If I want to go at a tinier but yet deeper, more precise cut, I might go with an NZ5 or an NZ6. So you can change out your tips and make your tips work for you, and as well as the energy within the machine as it's preset. So that's kind of a nice function here, which is a familiar thing for us as we're used to using burrs. So the tip kind of is like a burr, but it's not, okay? When prepping a crown, we want to make sure we're thinking about going for something that's broader and is more shallow there for us, and we'll kind of show those examples of that in the cases later. So we can pick the tip to help pick the procedure. Another barrier that we might come across is that this is just a different way to think about it. A lot of times I come across practitioners that really aren't as apt to incorporate the hard tissue portion of the laser field because they're so used to doing it the more traditional route. Excuse me. So I hope this is an eye-opening experience for you here, where we can see more of how we might be able to make this more efficient in your chair time and quicker. We just have to open up our minds and think about it a little differently. This next series of slides here is going to take us through how we actually get the little wedge cuts out of the tooth with the laser through the tip. Once again, we do not touch it to the tooth structure. Excuse me. We're going to hover away from this area and about a 2 millimeter distance away, about a 1 to 2 millimeters away with the gold to be able to have the effect on the tooth. If we come too close to the tooth, we're going to push that destructive energy down deeper, and it's not going to have the effect we want. If we're more than 2 millimeters away from the tooth where we want to have the effect, once again, we're not going to have the effect that we're desiring to have. That's one of the things I really love about how this laser in particular is calibrated. It's very, very precise, very precise. So I'm very safe in removing the amount of tooth structure where I want to remove it, all right? So we aim that beam there and we turn on the laser and it takes a very finite wedge away. If we think back to that table where it showed us how the tips work for us, this is that little wedge diagram that they had here. So this cross-sectional tooth, we turn it the other way, and we literally turn the tip the other direction. So we're going zap, zap. We turn it straight down again, And once again, what I want you to appreciate is that it only goes in this direction, okay? So it's very controlled. It's not going deeper because this is where the laser energy is absorbed within. And so now, in 3 little very controlled movements, we've created a beautiful isthmus in the middle of this tooth in a very controlled fashion. The speed that we move the tip, we're used to in pediatrics, working fast. You got to get that 330 in there and cut your prep. You only have a small amount of time to work with the kid, and we're more of that go, go, go type mentality for the most part there. We've got to work fast and quick. We've got to slow down just a little bit more to let that laser energy work for you. So that's a common barrier and a common issue that I see when I'm training pediatric dentists and training dentists to utilize the laser for hard tissues. We've got to slow down and let the energy work for us. Just a little bit. You don't have to go real slow, but just a little bit makes all the difference. This is a great soft tissue example on a cadaver here, on a dog cadaver, where we're moving at a rapid pace here, so zoop, and then we're moving at a slower pace here. So the laser energy was absorbed more in a deeper levels of the tissue here and less through here. So thus this shows us how we can have a greater effect if we just move a little slower, all right? And so we want to keep that in mind. The overall distance from the tooth, as we talked about, is very important. So we want to be about 1 millimeter or so away. So in my mind, I'm always thinking about 1 to 2 millimeters. If I'm touching the tooth, that's a no-no, all right? We don't touch the tooth with the tip. So for the best results, we don't touch the tooth, we don't touch the tissue there, and we hover slowly over the top of it, all right? That's gonna help us have the best results. I really love this slide. This was a really eye-opening slide to me. This is more in the soft tissue realm, but I think it really holds true when we're thinking about the use of the laser in general. This is showing the zone of necrosis. So basically the laser's effect on soft tissue. So when we're looking at electrosurge, which is commonly used for several procedures in general dentistry, we don't use it a lot in pediatrics, it's going to have a cell necrosis, so the death of 1,000 to 1,500 cell layer deep. Okay, that's pretty large, okay? And that's gonna mean more post-operative inflammation, more potential pain and discomfort afterwards, and also potentially more scarring. The more cell layers you damage, the more the body has to overcome. With a traditional scalpel in the soft tissue, we're gonna have about 100 to 300 cell layers of necrosis. For the diode, depending on what the setting, you'll get less than that. And the water lace, so the laser we're discussing today and focusing on, has about 5 to 10 cell layers. So as I translate that over to hard tissue, that's just more of that thought that it's a very controlled destruction of the tissue. It's very, very predictable in its use. And so that's more minimally invasive. I'm able to remove more of just exactly the tooth structure I want because that laser beam focuses it right where it is. It's attracted a lot to that water. So in the cases, I'll show you how it literally blows the caries away and leaves the nice sound tooth structure behind. So you're really able to preserve more of the healthy tooth and have a lot more conservative, smaller preps in a more efficient manner. So let's dive in more to the restorative side of things and kind of leave the more didactic end of the understanding. So we're going to touch on composites and crowns and how to utilize that in some cases that we have here with the laser. So some benefits for the patient when we're looking at doing this. No local anesthesia. So there's a study I'll show you in a minute that was released in JADA where they had 98% success rate by utilizing the laser with no anesthetic. That is a huge number, a huge number. I personally don't think my number is that high. And when you're initially integrating the laser into your practice, you're going to be nowhere that high. We have to slowly learn how to pick the proper patient and how to work it into our practice. So be patient with yourself and make sure we start on positive patients where we know we can help them have an easy appointment and not a more difficult one. And we'll talk a little bit about that in a little bit too, but that will help you early on gain confidence in utilizing the laser so that we can help all those kids later when you become more adept at using it. There's no vibration with the laser, and so some children, that can be their main concern. If you've ever had this slow speed handpiece and a round bar used on yourself, it's quite memorable how your head can shake when you use it. Even your hand when operating it sometimes can get a little bit of that vibration going through you. The other big thing that I focus on a lot is that there's not a lot of post-operative instructions afterwards. That child can eat and drink normally. That child can resume their normal activity afterwards. We ourselves normally call it a success by our standards if the child sits in the chair, does well, we get a great looking composite, or we get our crown on, it didn't take a lot of time and it went smoothly. That's a great success by our standards. That's a Frankel 4 child. Awesome job. What we don't always take into consideration is how the kid did after you leaned them up from the chair. Did they become overwhelmed? Did they have a meltdown by the feeling in their mouth? Did they get to check out and then have an epic meltdown there with mom at checkout while she's trying to get everything taken care of and they're throwing a big fit because they don't like the way it feels? Or were they stoic little soldiers until they got to the car and at the red light they're having a huge fit because they thought it was all over and yet now they still feel this? And why do they still feel that? We have a lot of parents that come to our practices that I'm within because we're able to offer these procedures without that. And that can be a huge source of anxiety for the parent. We have many parents that I see that don't want their child to go through a restorative procedure for the sheer fact of not that their child won't sit still to do it, not that they don't want to pay for it, it's sheer the fact that they don't want to deal with the aftermath. We don't always think about the aftermath, but the parent does. And that is a huge relief to the parent of knowing that they don't have to worry about that. And so that's huge in my department in helping my children that I see have the best experience they can have. For the doctor's benefit, no local anesthetic. We'll talk a little bit more about how that can benefit us. More precision and control so we can have a safe working lead. When I'm doing my infant frenectomies, if that baby moves around just a little bit while I'm working on it, I feel like I'm in great control. I'm not worried about nicking or having effect on something else around it. Same thing when I'm working on a tooth. If the kid moves with the 330, oh my gosh, did I just nick number 30 on a permanent tooth? Oh no. Not with the laser, okay? And so I have more confidence in the control of my procedure and the conservativeness of that surface decontamination where we're talking about the bacterial kind of load decreasing and kind of semi-sterilizing the area. And also the concept of the surface preparation and the removal of the smear layer. With the laser, there's technically no smear layer there. And so it prepares and removes tooth structure differently than our traditional rotary hand pieces do, okay? I love this study. This kind of is a core part of the curriculum in our residency programs here in the United States. And it was an eye-opening article when I read it when I was in residency. What this article is looking at is adverse events, AKA normally deaths of children following dental procedures, okay? The 41% of these malpractice insurance claims that had bad outcomes or bad adverse events, it was noted that that child had an overdose of local anesthesia. So let's just, for the sake of it, round that number up to 50%. We'll say 50% of these malpractice claims were due to local anesthetic overdoses. That is huge. That is devastating. And that to me shakes me to the core. We use local anesthesia all the time. We become almost numb to the fact of what that is. It is a medication. In adults, it's a lot safer, but in children, particularly younger children, we really have to concentrate on the amount we're giving it. And then if we're coupling it with other anesthetic medications, we really can find ourselves in a tough situation where there's not a reversal agent for it. So thus, if we're able to eliminate local anesthesia from our armamentarium, from our procedure, in my opinion, I find it much safer for my children. And I find parents really accept the procedures a lot more. So a pro tip here, we are trying to make these procedures as safe as we can, and I believe that they're safer without local anesthesia, and I'm not worried as much about the interactions of those medications. So how does the laser analgesia work? Yes, it does. Here's that study that I was talking about here that was from JADA, so a very well-respected dental journal there, where they found for composite restorations that with an erbium laser, it's very important that we look at the active medium or the type of laser there. This is an erbium laser. You can't really always compare the different types of lasers to one another through these studies. We really want to make sure we're trying to focus on the laser in question, all right? Which for this talk is an erbium. This is another article that talks about an erbium laser where it looks at extensive caries, so large cavities and stainless steel crown usage. And we found in this study that they eliminated the need for local anesthesia. And I myself do stainless steel crowns with the laser without numbing them up. I've done an 8-pack, so 8 posterior stainless steel crowns on a child that was at very high cavity risk and had very large cavities. I did that under 30 minutes without numbing the kid up. They did great. Now, not every child may do that good, but that child did. And we saved them many appointments and it helped them have a great experience with the laser. It was an amazing moment for the patient, for the parent, and for myself and the staff. And so these are really great rapport builders, not just with the parents, but with your staff as well. So does the patient feel something? Yes. So I've had several staff members that I've done procedures on and fillings on, and they normally always report a warm, tingly sensation. So we want to prepare the child for that, all right? We don't just want to turn on the laser and start using it. We want to prepare them for it. We want to describe how it's going to feel. So it's not pain necessarily, but it's a sensation. And so a lot of times nitrous helps them so much not focus on those weird sensations that they feel. We already know that in general. And so definitely that helps us with the patient's acceptance of the laser as well. So a lot of times I'm recommending nitrous oxide for my patients. So why might the child tell us that it hurts? Sometimes early practitioners that are integrating this in, they struggle. Oh, the kid, I just am having trouble keeping the kid comfortable. I'm having trouble being able to manage them and I'm not sure if they're hurting or what. And so most of the time I find if the child really is not liking that and is saying, oh, it hurts, it hurts, it hurts. Of course, I'm not ignoring what they're telling me, but most of the time that child doesn't like anything, okay? They're not gonna like the high speed. They're not gonna like the vibration of the slow speed. They're not gonna like the nitrous notes. They're not gonna like the ice light. So if you get that child that's not liking all of those things, then the laser is not a magic wand that's going to make it all better, okay? It's another adjunct that we're putting in to help make it more efficient for you and the child. And so it's not a miracle worker here, okay? And so we have to help understand that we may need to stop that appointment and come up with a better behavior management strategy, okay? And so a lot of times a little tell, show, do goes a long way, all right? And so we may be starting off with too much power, so you may have it on too high of a setting right out of the bat, so you may need to turn it down a little bit. We might be moving too fast, as I talked about going slow, so we might need to slow it down a little bit. You might be not properly having that laser beam aimed and touching the tooth. So there's a couple of different ways we can troubleshoot through that if the child's reporting symptoms. Now, is it a failure if I have to give a shot? No. In my book, I don't call that a failure. I am worried about the patient's overall experience and keeping them comfortable. I'm doing this so that they can be comfortable. And if the laser is not helping them for some reason, then I will give them an injection in a heartbeat to help make sure we have them have a best appointment, okay? And very far and few in between do I actually have to give an injection to, but sometimes I do. And I never promise the parent that I'm not gonna do an injection. I'm always just talking about how we're gonna help utilize the laser to help them have a better experience, and hopefully we're not gonna have to do the shot. So less is more. As we're in this COVID experience in a global situation, as we're all across the globe dealing with this, from Dallas to London to Singapore, we're all kind of finding ourselves revisiting this aerosol and water and all these things we're putting in the mouth. And the ADA here has recommended this concept of less is more, okay? And so the BioLace water laser has about 80% less than the traditional high-speed handpiece does. And so a lot less water there. And so less water theoretically is going to be translating to less aerosols for us. This is a great visual here of kind of showing us on the right is going to be a traditional high-speed handpiece with the water spraying down here, and we're having that blast coming out. Where here on the left, we've got the gold handpiece on the I+, which is spraying water that just drips down. And so we're having less water coming out of that. So thus we can visually see a lot less aerosol, a lot less spray going into the air as well. So that is in the forefront of our minds right now. Here's another great diagram showing the difference in the water, okay? And so on the right here, we've got the traditional handpiece, and we've got here on the left, the water lace, and we're gonna have a time lapse here at 2 times the speed. Here, as we're seeing at about 30 seconds, we're over halfway full, almost 25 mLs in this beaker, where we haven't even made it to 5 over here. And we're gonna get all the way to the top and overflow before we've even made it to a minute. And we're not even to 10 mLs over here. So we can see how the water lace can efficiently function with less water in our oral environment than our traditional high-speed handpiece with water would. And so currently in our COVID times, as I was saying, that can be something that we might want to consider when utilizing something in our material. Let's take some time and look at composite restorations here, and we'll walk through a couple of cases. I've hand selected a few here that we'll cover today, and then on Friday, I hope you'll join me again, and I'll review some other cases as well. And I kind of want to walk through the process here for you, and we'll revisit some of those, some different ones on Friday. So let's take into consideration tooth number B. So here's tooth number B with a distal discoloration. Classically, tooth B and I, for one, you know, they always just end up with those distal caries there that we're trying to manage that have progressed. And this child's no different. So here's our bite wing for this kiddo. And we've had a little bit of incipience here, a little bit of incipience there, and a little bit more activity here in the B area. Now, a little backstory on this kid. He was an SDF kid. We managed him with SDF. And what we're seeing is that this is a follow-up radiograph. And we've had great success in these 3 areas. We're winning the war, but we've lost one of the battles, okay? And so 3 out of the 4 is successful, but this one's a borderline one. And so I always like to present this in a way to the parent where we can help them have an active choice in it. And I've talked to the parent about managing more with STF or frequent visits and fluoride and flossing, or moving forward with the composite at this time, since we were seeing a change in the size from the last one to this one. And the parent, being very motivated and honestly was doing a great job of flossing and diet control, opted to go ahead and move forward with the composite, which I thought was a great choice. This is a mid-treatment clinical pictures here of kind of what we're walking through this on a comfort prep in a class 2 setting on the water lace, where we can see we've removed out kind of an isthmus area here into a dovetail and uncovered the marginal ridge. I did all of this with the laser, all right? And we'll see a little bit of that destruction here through the area. So a little bit of this denaturing of the enamel. Perfectly normal to see a little bit of that. That will, if you spray it with water, the majority of the time will rehydrate. So it really isn't damaged or anything. Sometimes it peels away really nicely when you refine it if you use a high-speed handpiece. What I love about this picture here is that we're seeing that zone of SDF, and then we're seeing that zone of infection underneath there. So I stopped the laser just shy so we could show you and capture that great image over a very conservative preparation starting here. And then we're going to turn the laser energy up. And that's what this is showing here on the left, is I turned the the laser up to a rapid prep setting. And then we were able to remove out all of the caries from this with the laser. It was attracted to all of that water and that liquid within that, and literally in controlled explosions, removed out very nice and tightly that infected layer, leaving a sound tooth structure behind. Now, I'm a traditional guy. I like my preps to look nice and clean and almost textbook-like, if you will, and I like for them to look good on x-rays and radiographs. And so I like to go back and refine and create a little bit more retention for my preparations and give us a little bit more of that old C factor that they talked to us about in our initial dental studies there. And so this is what the preparation finished looking like here. So a nice conservative retentive feature there on tooth number B. Now this tooth is not anesthetized, okay? I have not numbed this tooth. I have put a little bit of topical on either side here because now I'm gonna put a wedge and a band around that so that, of course, we don't glue the teeth together. So I'm going to restore it in the traditional fashion with etch and bond and then my composite restoration. Well, some individuals out there like to omit the etch situation from their preparations and their restorations and like to use the bond preparation to remove the smear layer and thus use that to prepare the tooth for the composite and the bond. I'm a little bit more traditional in the fashion where I just go ahead and etch. And so I like to make sure that we are getting the best results we can there. And so I'm an etcher. This is our post-operative clinical picture. What I love about this, look at the gums. Look how nice and healthy these gums are. If we had injected into these gums, they would be a little puffy, a little swollen. They'd be a little blanched because of the epinephrine. And so that child's gonna be sore through there. We were able to wedge nicely between there without really traumatizing the gums. Do we do that every time? No, sometimes we do traumatize the gums with that band and wedge, of course. Sometimes they do feel a little pressure, but I'm always preparing them for that, okay? And that doesn't tend to be a source of a time where we lose the child and their cooperation because I call it my tooth hug. We're gonna give that tooth a nice big hug. And then we polish it up, adjust the occlusion, all without doing any local anesthesia. This child was perfectly cooperative and did an excellent job for us. From start to finish, this took us about 10 minutes. So very, very efficient use of chair time because I'm not having to wait for my local anesthesia to take effect. We're sitting the child down, we're starting them on nitrous if we're gonna use that. We're putting topical on there while we're getting everything going. And then by the time we're ready, normally that soft tissue's got a little bit of that anesthesia that we need. And we go ahead and start the process with the laser. So it makes it great for same day treatment work-in where you might be trying to work somebody into the schedule, super efficient in reducing your overall chair time of you, the doctor, sitting in the chair. Let's take a look at secondary caries. I love this case because it was a child that presented with us with a large composite that had a defect. So they came to us this way. This was their initial appointment and they had secondary caries under here. So can we utilize the laser to remove a composite, clean out the caries, and to put another one in? Yes. So let's take a look at this. So we cleaned it off, and I always like to start off on bond prep, which is the lowest setting within our class 2 presets. I love that the laser that we utilize here has the presettings within it. It makes it really easy to utilize. And so I always like to start off on bond prep to kind of walk the child through the overall experience. I'm talking to them about how it sounds because it does sound different. A lot of times for practitioners that are looking into integrating a laser into their practice, that's one of the most alarming things. Oh my gosh, Ben, this laser sounds just awful. No child's gonna wanna cooperate for that. There's no way I'll get a kid to sit still, they'll say. Well, we've forgotten. We're so used to the high speed. That sounds terrible, that wee noise. It's so high pitched and so close to their ear. We're used to it, but we have to remember the child's not. And we're so used to talking the child through that. Well, now we have to talk them through this. It's no different. Once again, if the child can cooperate for that, they almost always can cooperate for this. So I start them off with that bond prep, which makes a little buzzing noise, and I get them used to the little tingle. I get them used to the water. I get them used to the air. I win them over to the experience there, and I love to call it my butterfly. Oh, we're gonna have a little butterfly that's flying around in your mouth. Oh, look, bzzz, there it goes. It's flying around. Oh, that butterfly is kissing your tooth. Do you feel it flapping its wings as it tickles your tooth? Who doesn't like butterflies? And so we want to make it fun. We want to make it interactive, and we want to make it something that they're going to want to do. And then I turn it up to comfort prep. And then it just melts the composite away on a medium setting here, which the comfort prep is designed to remove off an initial layer of that tooth structure. And I utilize that to go around the area circumferentially and remove out the composite and unveil underneath my secondary caries under there. Also, once again, we did not numb this tooth. I turn it up to rapid prep, which is the highest pre-setting there in our class 2 setting of the laser. And this was where the composite was before. I didn't remove any excess tooth structure. I removed only the defective composite that was there. How conservative. I love it. I didn't have to cut away any extra tooth structure. It melted out of there very easily. And then I go through here and remove the caries. And then I come back over with a high speed and just refine this. I put my band on and my wedge through, perfect isolation. I am always utilizing a isolite for mine. I love an isolite as opposed to rubber damp. And I'm also utilizing a high-speed suction, all right? And so I've got 2 sources of removal of that aerosol, the water and the air from the area there. And then we restore this composite. So we've ended up with a beautiful composite on what might have been a very tricky procedure. Nobody really looks forward to removing the composite and putting a large composite back in there. And definitely this went so much smoother than I had thought it was going to go. And that's why I love these cases. We don't wake up in the morning and get excited about coming in and removing secondary caries on a large composite on a small child. I don't get up in the morning and just jump for joy to do those. And so this really makes me have more job satisfaction and really helps win over your staff as well that's used to working through those difficult procedures. And it really is just always, our mouths just drop open. We can't believe it works so well. That's a really great feeling to have. Let's kind of dive here into the crown restorations as well. Now, I have to admit, you have to be a little brave your first time to try this. It takes a little bit of adventure and the proper patience to try it your first time, but I encourage you to give it a whirl and to get your feet wet and really make sure you've got the proper training on your laser that you're utilizing, but really pick that patient that you think would really be a good patient for you, and let's give it a try. And that's what this kid was. This was a chronic acid reflux kid. Bless his heart. See how these teeth are just so brittle and they're chipping away. And we were getting secondary caries, or we're getting those caries in between where it's just brittle in between those teeth. And thus we were crowning them to better preserve the tooth for them and to remove those caries. So we did this on a number of teeth for this child, unfortunately, but we're going to take a look specifically at tooth number S here. So once again, I start off in the bond prep mode, or the lowest level, and I go circumferentially around all over the tooth, over the top, over the sides, through the interproximal, and it just basically etches lightly the outer surface of the tooth. It gets the child used to the feeling. Now remember, that pulp was very close underneath here, so nature has naturally done a lot of the occlusal reduction for you in this case, so that's nice. We don't have as much tooth structure to work through to get to what we want, okay? But we also have to remember that this light works at a 1 to 2 millimeter working length. Now, how far is that pulp underneath there? I don't know, but I do know that we can see it slightly, so I'm concerned about it. So I'm not going to be aiming that laser beam directly over that pulp translucency there. I'm going to be mindful of that, okay? On a normal tooth that didn't have this erosion pattern, I wouldn't worry about it at all, because at that point, the destructive energy has dissipated, and the pulp is only going to receive a transmission of more of the positive light energy there. It's not going to be the destructive energy. So the pulp will not be irritated or have any adverse effects from the laser use, because this laser is honed into that 1 to 2 millimeter destructive working energy, okay? And so it works great for us. But I love this case because it plants that seed. We have to ever be mindful of that pulp, okay? So then after I finish my bond prep, you can see it doesn't look too much different, but in that brittle tooth enamel, we already have gotten removal of some of that just from that low setting. I'm going to turn it up onto comfort prep, and we're going to move around here. And I love to go interproximal first and do quite a bit of interproximal reduction with the laser. You can't quite appreciate the trough from this angle that I've created here, but the reason I like to remove the interproximal first is because I can do a modified Hall technique. If for whatever reason that child all of a sudden takes a turn for the worse, I know if I've broken contact on the interproximal, I can confidently get a crown on there in a very minimally invasive fashion, and I don't have to worry about it. And so that's another way I love to kind of mix different techniques here for my patient's best experience and to be able to offer them the best care I can. You're also going to notice in this, well, we've got, what is this? What is this? A little bit of the laser beam got the tissue there. That's okay. That'll turn over and heal just fine. Remember, it only works at about 5 cell layers. So this will literally just slough off in it, and probably by the end of the day, and it'll be fine by tomorrow. You'll also notice, oopsies, I angled that a little bit towards this tooth. Oh no. You'll notice here, I didn't. The laser beam is aimed straight down and is very controlled. So you're way less likely to nick this tooth here when you're utilizing the laser than you are if you're using a traditional burr that cuts on the side. Now, what about this section where, what did you do here, Ben? I angled it a little bit too far to the side. I'm going to spray a little water on that, and it's going to rehydrate, and it's going to turn back great. So it's not a defective area that is going to be an issue for that kid. So then I turn up the rapid prep, and I go over all of the surface of the tooth all around. This is taking me about 60 seconds to 2 minutes. I'm not spending a lot of time doing this. What this is doing for me is it's basically dehydrating or denaturing that outer enamel layer. And then I pick up my traditional diamond burr and I ring around the rosy and it peels right off of there. And the patient doesn't feel a thing. They're going to feel a little bit as you move interproximally, okay? And I put on that topical. I like to use the best topical ever. That's what it's called. And that really helps get you more of that numbness. Some practitioners like to do a little bit of interproximal injections there. Perfectly cool if that's what you want to do. I like to, once again, not do it, but sometimes I do go ahead and utilize that if I need to. You're going to notice a little bit more bleeding from your crown preps because you don't have that epinephrine that you had when you use your local with epi, okay? And that's perfectly fine. If you're a little worried about, oh, is that bleeding too much? I don't want them bleeding going out to mom or mom to see that much blood. Maybe she'll be worried about it. Well, voila, you have in this laser a hard tissue and a soft tissue. So there's a setting that is a laser bandage setting where we can go over that tissue to help it basically slightly cauterize the outside and stop the bleeding. The laser bandage setting within this laser is really great if you've got an area where like, oh, maybe that's bleeding a little bit more than I want it to post-operatively, just for the sake of the patient, okay? After we do this, I pop on my crown and try it on, and they're gonna feel a little tug as that seats down, and then I pop it off. Vast majority of kids have no issue with that, okay? I prepare them. We're gonna give that tooth a little hug. Oh, here it goes, hug. And they are, whoo, okay. Now, some kids might cry a little bit, and you may have to work through that. And if the parent's in the room, I'm always preparing them. Well, Mom, we've done all this work. Johnny's done great. Now, this he might find a little bit exciting for just a minute, but normally it's not like we lost the kid at this point. It's normally just a little bit of discomfort or a little bit of pressure that they're having a difficult time working through, and that's what they're feeling. So I really hardly ever lose the kid at the point of cementing the crown, okay? And so I know that's a lot of fears that practitioners may have with this, but definitely helping your child to prepare them for that feeling is important. So just another view of what our traditional crown prep looks like. So to kind of wrap it up for us here, a couple of the things I wanted to highlight for us today is really kind of the efficiency manner of removing that tooth structure of the tooth with this laser and other lasers on the market in particular, we're able to remove those caries very conservatively in a very controlled manner and introduce more minimally invasive techniques, such as maybe a modified Hall crown technique for a child. I have a couple of kids that they only have a very short attention span, and I want to remove off a little bit of tooth structure there and then get the crown on for them to help them have a successful full coverage. And I know I only have maybe just a couple of minutes of working time. This can be excellent for them. Sometimes our autistic kids that of course process sensations differently, a lot of times this may be a very helpful adjunct that we may want to try. If we have an autistic child that may struggle with the vibrations of the traditional handpiece, they may find this a lot more receptive. Or once again, they may find that tingling very upsetting. And so I never promise anything to the parent because I'm not the patient. We have to help our patients have the best experience and help them work through that. And this is where I find that when we do that, the patients have a lot better of an experience too. Once again, I find this to be a very safe manner, not just in how controlled the laser beam is, but also that we're able to help them have less injections there and less potential for lidocaine overdoses if, God forbid, we might not have been paying attention or we were to be distracted, or if something else was to be interacting with that as well. So just removing that from the table in general can help make our procedures a little bit more on the safer end for that. And of course, those post-operative situations we may not consider necessarily, but maybe paramount to the overall experience for that family. And also that concept of less water, less aerosol. So less is more sometimes, particularly in our current COVID situation, and less chair time. Once again, children will only cooperate for a small finite amount of time, maybe 10 to 15 minutes of good chair working time. If we can capitalize that more and really be able to be there and capitalize on that working time from that child, that's really going to help increase our success of our procedures and the success of the child's experience. And also those same day treatments. I love to work in a good same day treatment for a parent. A lot of times they appreciate not having to take off work, having to take the kid out of school, and not having to worry about reorchestrating all that with our schedule, their schedule, soccer practice, band practice, all of that. When we can easily work that in and we can tell them, oh, it'll take about 15 minutes or so, give them a short timeline, and we can easily work that in and get that accomplished with the laser. That's a really great service for the patient and also a service for your practice in general. Helps increase your production as well. Once again, I welcome all questions and I look forward to answering those. In just a little bit, we'll take some questions from today. We won't have time to answer everyone's questions, but I will review those questions and we'll put those together again for us in a Q&A panel on Friday, the 15th coming up. So please tune back in for part 2 of this. I'll revisit a few different cases here that I've selected out that I found very eye-opening cases to discuss, and then to help answer your questions and maybe troubleshoot some issues you're having or help encourage you in some way in introducing the laser into your practice. So the end here, if you would like to contact me or reach out to me, really the best way, I love interacting on social media through Facebook. You can message me or follow me there. I post lots of great things on my Facebook, normally weekly, if not daily there. And this is my son, Dotson, our middle son here, as he's getting on the plane to Disney. As I said, my wife and I love to go to Disney World, even though we can't go now. We're hoping to be able to make it this year. He was on the plane with Forky on his head, ready to go see Mickey Mouse. So I hope that the excitement that I have for this and the passion that I have to help children through utilizing these lasers has been expressed to you today. And I thank you so much for your time and your efforts in helping take care of the children across the world. Thank you.